morning everyone. Today my topic is about hyperprolactinemia and infertility. So first of all, what is the need for hyperprolactinemia is common hypothalamic pituitary dysfunction and one of the causes for the irregular menstruation and also the infertility amongst the young women. And the main mechanism and pathophysiology is the prolactin acts through the prolactin receptors like the His-peptide-1 receptors, which directly acts on GnRH neurons to reduce the GnRH, and later it will reduce LH and FSH, and which leads to the anovulation and hypogonadotrophic infertility. And in males it leads to the spermatogenesis. And the main causes of hyperprolactinemia is, we also know that, and the physiological causes are pregnancy, nursing, nipple stimulation, exercise and stress, sleep research. And the pharmacological causes are haloperidol, risperidol, monoamine oxidase inhibitors, cimetidine and verapamil. And the pathological causes are pituitary adenomas like prolactinomas, hypothyroidism, chronic renal failure, severe liver dysfunction. And what are the symptoms we see in hyperprolactinemia is in female menstrual disorders, and in anovulation and decreased luteal dysfunction is seen, and oligomenorrhea and amenorrhea, infertility and galactorrhea, decreased quality of life in women, and decreased bone mineral density and sexual dysfunction. In males, mostly we will not take the history of males, but we have to take the history. Mostly we will see decreased libido, erectile dysfunctions and decreased body height, galactorrhea, gynecomastia and bilateral temporal visual field defects. Oligospermia is also one of the symptoms. So what is the need for hyperprolactinemia and infertility is actually decreased GnRH production leads to the granulosa cell dysfunction, inhibition of corpus luteum and endometrial dysfunction and decreased implantation in females. So why should we need the prolactin is actually it is need for maturity, oocyte maturation and fertilizability, early corpus luteum formation and survival, and improvement of blastocyst implantation potential, and it is also helpful in embryo endometrial synchrony, and it acts as a pro-survival factor for the low motile sperm, and also involvement in decentralization. So prolactin normal values are 0 to 20. If it is 21 to 199, don't jump into the treatment. We have to repeat the sample, reassess the sample again after 1 month, and later if it is more than 200, we have to consider it as a macroprolactinemia. If it is 21 to 199, we have to go for 21 to 199, go for imaging techniques like MRI. And one more thing is, this is a flow chart showing that we have to take the history and any drug use or any physiological conditions are seen, and we have to always repeat the prolactin after 1 month duration, and if it is normal, just leave it off. If it is elevated, we also have to check the thyroid TSH levels. If it is normal TSH level, we have to go for MRI if there is any hyperprolactinemia to conclude whether there is a microadenoma or macroadenoma. And if it is elevated along with TSH, we have to treat hypothyroidism and go for repeat checks, like repeat sample collection after 6 to 12 weeks. And this is the newest flowchart showing that, see, already if they are taking any drugs, we have to stop the drugs, taking the opinion who have started those previous consultations. And if it is TSH and increased TSH, we have to go for the liver function test and renal function test, and also we have to exclude the beta HCG, whether there is a pregnancy or not. If there is normal, only the hyperprolactinemia is there, we have to go for MRI. So previously we used to check the hyperprolactinemia to find out the macroprolactinemia. Macroprolactinemia is checked through the polyethylene glycol and gel chromatography, and IgG prolactin we used to check with protein A and G, and later we have to check the anti women actually. So in men, macroprolactinemias are seen. So explore the adenomas, pituitary gland tumors and prolactinomas. Adenomas are non-cancerous tumors and these are asymptomatic, they grow slowly and they secrete growth hormone ACTH, TSH and prolactin, and surgery is the main treatment for these adenomas. But for prolactinomas, tumors of the pituitary gland and they secrete only the prolactin hormone in high levels. Females, children are mostly affected in this. Prolactinomas are medically corrected. So already we also know that bromocriptine, cabergoline and quinabolide are the treatment of choice for this prolactin hyperprolactin. Actually in this slide I want to say that actually bromocriptine is half-life is very short half-life. So it is only 8 to 3.3 hours. Cabergoline it is 65 hours and quinabolide it is 22. And the main side effects is bromocriptine. The tolerance is more but resistance to multiple daily doses. And bromocriptine we can use for the pregnancy also, during pregnancy also. But cabergoline it is high efficacy. Only it can be used in bromocriptine resistant patients. We can prescribe weekly or twice in a weekly doses. And possible risk factors for cabergoline is fibrotic valvular heart diseases. So pituitary tumors we have go with the treatment like microadenomas. They rarely progress in size after the treatment. They repeat the imaging in 12 months. After 2 years of the treatment, they will come to normal, like prolactin come to the normal and we can taper off the treatment. And however, there is a 25 to 70% of recurrence rate in microadenoma. But in macroadenoma, the prolactin levels, if they are not improving, new symptoms are arising, we have to image further after 3 to 4 months, 3 to 6 months. And the prolactin levels are improving, imaging repeated in 6 to 12 months. And we mostly see in our macroadenoma is visual field defects. So this is the treatment for the pituitary tumors. For the surgical therapy, most of the normal person, like 53% of the patients will become normal and the pregnancy will be, can be continued. And radiation therapy, 1/3 of the patients, normalization of their prolactin levels will be seen. So the risk factors are surgical resection, hypopituitarism, CSF leak, infection and diabetes insipidus. Radiation therapy, hypopituitarism, cranial nerve damage and secondary tumor formation. So the infertility part we can start after the normal prolactin levels are seen. We can start with letrozole, clomifene along with HCG triggers. And after that we can go for controlled ovarian stimulation with HMG, FSH and HCG triggers. IVF and ICSI can be planned later. So the pulsatile GnRH analogs are advised in males along with FSH and HCGs. Like weekly 10,000 HCG, 10,000 international units we can advise for this male patients. Actually dopamine agonist can be started in IVF treatment from the day 4 of preceding cycles until 7 days before stimulation in patients treated with long agonist protocols and HMG can be given. Administration of dopamine agonist successful for the obtaining a pregnancy in previous IVF failure patients. So the studies are showing that in IVF when they have started along with cabergoline, increased increased stimulated cycles, prolactin levels are increased than in spontaneous cycles. And during ovum pickup also prolactin is increased because of stress for the patient. And before and after HCG increase, prolactin is seen. And it is also increased in luteal phase. There is a bimodal serum prolactin profile with peaks 1 and 9 days after the maximum serum LH values. So the drug of the choice is cabergoline, and in most patients it is seen a normalization of the prolactin in levels in 2 months. So we can repeat the test later. And the patients with tumors shrinkage is seen with cabergoline treatment and compared to the 75% with bromocriptine. Return of the fertility is seen in more than 50% after treatment with cabergoline. And very large like giant prolactinomas, cabergoline is the drug of the choice. So the main conclusion take-home message is, please repeat the hyperprolactinemia after taking the correct history, and we have to screen prolactin along with thyroid TSH also. And morning sample is the preferable sample. We have to take the history of both partners, male and female, and we have to take the samples of prolactin also for the male and female. And the drug of the choice is cabergoline. For the ovulation or induction, we have to go with the clomiphene citrate and letrozole, HMG and FSH. And the dopamine